About 10 years ago, we embarked on a project in the US and then in Europe to collect tumor samples from men with advanced drug-resistant prostate cancer and subject them to next-generation sequencing. And that study found that up to 30% of men have alterations in genes that are responsible for repairing DNA, so repairing the genetic material in that cancer. These are genes, some of which were previously shown to be altered in breast and ovarian cancer. And there was a bit of a light bulb moment. These cancers could therefore benefit from drugs that were at the time being tested in ovarian and breast cancer. The next thing that followed was that we showed that these men have a worse outcome. That cancer progresses on treatment much faster, it grows much faster, it's more aggressive, and sadly they have a shorter life expectancy. And that's been the reality. For 10-15 years we've had good treatments. The first drug that we developed as a second-generation hormonal therapy is called abiraterone. That was followed by a number of other similar drugs. But as I implied, this group of men who have alterations in these genes have a much shorter benefit from treatment and consequently a much shorter life expectancy. What the Magnitude trial did was test tissue and blood and germline, identify these alterations, and then for men who had the alteration and men without the alteration, they were separately, and really what are two separate trials, randomized to receive, everyone received abiraterone, the standard of care, and half of the men received niraparib, which is a potent PARP inhibitor, which has been used, as I said earlier, in breast and ovarian cancer for many years now. The aim was to show a benefit with the drug. And then the group with the gene most commonly altered, which is BRCA2, that group have close to 50% reduction in time to progression. This is especially given what I said earlier, a group that have a bad outcome on abiraterone, a very significant finding. What are the next steps? So importantly, the study needs to continue. We need to continue to follow up patients and ascertain whether there is a benefit in terms of life expectancy, survival. The trial had two co-primary endpoints. The first was rPFS, which was reported last week at ASCO, and the second is overall survival. So this was predefined that we will continue to follow patients up. Of course, my bias is we will see an improvement in life expectancy, which such a significant delay to progression, that's probably going to translate into an improvement in survival, but we'll have to wait and see. The second consideration is we see side effects. With PARP inhibitors, compared to chemotherapy, they're very well tolerated, but we do see some nausea, some drops in blood indices, so drops in red blood cells, less commonly other indices, some fatigue. So we don't want to use treatments for everyone. We really need to carefully weigh as oncologists that benefit-risk ratio, but clearly with the hazard ratio we see here, I think there's clearly a tilt in favor of using treatment. We're also testing niraparib early in the disease setting. So this was a population of patients who had become resistant to hormone therapy, so had developed castration-resistant prostate cancer. And using the same model, we're now testing a specific group of patients at start of hormone therapy. So patients again are screened, those who have an alteration in one of these genes, most commonly BRCA2, are then randomized to abiraterone or abiraterone niraparib. So that's what's in the future. I guess that will take 3 or 4 years, and then we'll understand whether moving this treatment even earlier in the treatment paradigm has the same benefit as we're seeing in the Magnitude trial.